So it's a Thursday tradition that we're missing half the class, I guess.
Show will go on.
This is starting
You're
to,
looking at your A students right here.
I know, but I'm
All
worried
your
about,
favorite people are right here.
I'm worried about the other ones.
Did you say it'd be here?
Oh, wow.
Huh?
Yes, it's not here.
Yeah,
Ben has an excuse.
Ben's gone.
Yeah, Ben has an
Finally
excuse.
unboxed, but didn't.
Okay, so today we are going to tackle some information that on paper, on your syllabus, looks like we're going to cover a lot of information, and we're really not. We're going to be covering bits and pieces from parts of the skeletal system. Parts will help you in lab as well. But there's definitely going to be some things today that will be on the exam, and I'll give you those hints. But again, as you prepare for Tuesday's test, remember you always focus in on things that we've talked about and emphasized in class. You're going to be using your lecture outlines primarily as your source. You know, for example, on the next exam, there's going to be a table with tissues. You know there's going to be some slides in the beginning that I'm going to show you, specifically the ones that we took pictures of in class. So that, I think, shouldn't be too scary. There will be a few slides dealing with today's lecture as well, and I'll make sure to tell you which ones will be on there. So today is one of those lectures that some professors will, look at it in a different way than I do. Instead of just talking about bones and showing you bones, which would be awful, I'm going to focus in on some other things that are kind of interesting, and save all the bones and bones for lab. So that's the plan. All right, so if you look at the big screen, this kind of gives you an overview of what we have on the next test. We're starting with histology. We're moving through integuments, which is skin and hair. And then we get into bone. And then we're getting into the skeletal system. So I would say that after Tuesday's test, we move into the world of muscles. But that's going to be a short little blip. It's like 3 lectures and then we have a test. But they're going to be power lectures, like hard lectures. So in about 2.5 weeks, you'll have 3 exams down. And you probably will have at some point an idea of where you're headed for your final grade, since there's only really 4 exams in this session. So the next 2.5 weeks are important, but just take it a day at a time. Don't feel overwhelmed. And if you're ever to a point where you're just like panicking, you can do what Megan did, and you can come and talk to me and ask me questions. You can text me. You might remember that over the weekend. So you can text me during a Saturday and Sunday. So, I don't want you to feel stressed out. All right. So when we look at this structure, a lot of people say, "Oh, I remember in 6th grade, 206 bones. Do I know all 206 bones?" No. In fact, the only thing that I want to emphasize in lecture is something like we did in lab. I want you to be able to kind of appreciate the organization of the skeletal system. So I want you to know that there is an axial skeleton and there is an appendicular skeleton. So just like we talked about in lab on Tuesday, and we'll talk about it tonight, be able to kind of organize bones that we looked at in lab and say, okay, those are axial skeleton bones and these are appendicular bones, but do you have to know every bone for the lecture test? No way. In lab on Tuesday and lab tonight, you had an opportunity to pick up some bones for the first time and kind of notice that they are different in shape, and they have some nooks and crannies, or they have some kind of pointy places or rounded out places. And you're going to learn some of those bone markings for the lab test, which is in a couple weeks. But you don't have to know the markings for these bones for the lecture test. So what I think I'm gonna do is I'm gonna pick some bones, like four total out of 200 and whatever. 4, you can do 4. And I want you to know the bone markings on each one of these bones. Now, I think the figure numbers that I have up here might refer to the blue version. I think it's the blue version. So don't panic if these figure numbers don't match. Here's what I want you to remember. You need to know the anterior and posterior view of the sacrum. Of the sacrum, okay? So on the exam, you know that the first 10, 12 questions, I'm turning off the lights, right? I'm gonna show you some slides of tissues. One of the slides I will also show you will be this, minus the labels. And I will point to the holes, or I'll point to something on here. It will be multiple choice, so you don't have to remember how to spell it. And you'll just tell me the name of the structure or the bone marking of the sacrum. So this is one where you say, I should study this particular bone for the lecture test on Tuesday. So this figure in your book is an easy one to find, right? It's in chapter 8, I believe. But if you don't have the book, you can always take a picture of this and you'll be good. Everybody okay? So this is one. Everybody okay? Another bone that I want you to know is the typical vertebrae. So typical vertebrae have something called a body, something called a spinous process, and something called a transverse process. So you need to know 3 things from a vertebrae. That's not asking a lot. Again, the body, the transverse processes, and the spinous process. That's it. So I'll probably show you a vertebrae and ask you, what is this structure? That should be really easy. And then the last bone is the scapula, and this is one in which you have to know some detail for lab, but you have to know all of these bone markings of the scapula for the lecture test. So in some schools, the bone test is nothing but bone markings, and it's a lot of memorization. For my bone test, you have to just know 3 or 4 bones total. So that should be okay, right? So sacrum, vertebrae, and scapula. Okay, so that's it. That's it. Those 3 bones are the only ones you need to know markings from. Now I'm going to have a question on the exam, so I'm giving you lots of questions on the exam, right, for all 6 of you that are here. So another question that I have on the exam is, I will give you this imaginary box, okay? So play this game at home, do this yourself. And I'll say, in this box is a humerus, a femur, a rib, a clavicle, whatever. And I'll say, how many in this imaginary box are appendicular? So the answer on the test would be a number. How many are from the axial skeleton? So you have to know appendicular and axial, which if you've had lab on Tuesday, you should be good. And if you go to lab tonight, after lab tonight, you should be good. So this is a good thing where we have lab and lecture overlapping. One is helping the other. There's no better example of learning about something and then going to lab and actually touching it. For a lot of people, that really helps. So it's really simple for axial, is that you only have to learn this list because any other bone is appendicular. So we talked about all of these bones in lab on Tuesday. You'll hear it again from me. Okay. Now with the skull, you do not have to know any bone markings for the lecture test, but you can see that there are some cavities, and this should bring back memories from test 1. Some of you remember that the cranial cavity contains the brain, so easy, right? But what I want to talk about are some cavities that you can only see if you slice the skull. And I don't think we had any models of this in lab, so I don't think it'll be on the lab test. But I will ask you about the sinuses in the lecture test. So let's talk about those. First of all, what is a sinus? A sinus is a hole, literally an open space inside of a bone. So only some bones have sinuses. Like, look, your forehead, which is called your frontal bone right here. So this is called your frontal sinus. The bone on your upper lip is called your maxilla. There's a maxillary sinus. And then we have two that are kind of deep behind our nose, called the ethmoid and sphenoid sinus. So we have 4 sinuses. The purpose, here we go, is to, 1, lighten the load, make the skull a little lighter. The other purpose is to help with speech. So when these hollow openings become infected, 1, we feel pressure, right? Like, oh man, I can feel my upper cheek is like pounding. Or I have a headache. Look, right here. I can tell you where I feel pressure. Well, guess what? There's fluid in that hollow space. It's a sinus infection, right? So when we think of sinuses, we know the purpose, we know the names of them. Put a star by the maxillary sinus in your nose. The maxillary is the largest of the 4 sinuses. Okay. Something in lab that we briefly talked about with the skull is the fact that during development in our mom, we have these soft spots. A lot of people call them soft spots when their babies are born. But we're going to call these places of cartilage, virgin cartilage, we're calling them fontanelles. So a fontanelle is a place where we have cartilage, and they have 2 purposes. I think you should know these purposes. 1 is to provide expansion and movement during brain development. So I would say from birth up until about early toddler age, a baby's head is larger in proportion to their body than normal because their brain is growing so fast. So we don't have this like bony cage that says, stop, you can't grow, you can't get bigger. We have a bony structure that will expand and show some flexibility. So yay for fontanelles. It's also important for vaginal deliveries. So when we think of the birth process, babies who are born vaginally come out looking beat up, scratched, their heads all messed up. And it's because we have flexibility. When my first son was born, everything was going great with the whole birthing process. And then my son got stuck right as he was ready to exit. And my wife's OB-GYN had to put a suction cup literally on his head. And when he popped out, his head had a rim around his skull. What are you doing? You stalking me? Yeah. You doing okay?
Yeah.
Is this your tape recorder? You want to put it up there?
I hope I charged it. I'll get it.
So he had this like rim around the skull where the suction cup attached, and his skull was like this pointy thing. And so, for my wife and I, it was grandkid number 1 on both sides of the family. So my mom and dad, my wife's parents were there. I had to go ahead and tell them, hey, listen, everything's great, but Zach has a pointy head. That little beanie that they put on in Good Sam, it's not staying on. So, it just says that the skull was very pliable, moldable, right? So thank you. And I think I told the story in lab on Tuesday, is that I always, as a dad, got really nervous that, my kid would fall off something or roll off something and hit something sharp, because there's no protection here. In fact, you can take your finger and take the pulse of an infant because the brain is gonna go like this. It's gonna, and you can see it. I mean, next time you're around a fresh baby, like under the age of 6 months, just go like this, right there, just go, let me take the pulse. I swear. I promise. All right, so you do not have to know the individual names of fontanelles, you just have to know what a fontanelle is. Last thing I want you to write down in your notes is what happens to a fontanelle when the skull becomes mature. It becomes an immovable joint. It becomes a suture. So you may have to learn some suture names in lab tonight. And that means that the fontanelle is no longer there. If you're into like CSI, see, I can just talk about this stuff forever. If you're into CSI and you've come upon a skull like in a creek bed, you know, or whatever, and you say, hey, how old is that skull? If you see, you know, a small skull with fontanelles, obviously it's really young. But listen to this, if you see a skull where there's no suture lines, it means that over many, many years of remodeling, dissolving, and building, that somebody in their 60s, 70s, and 80s may not even have a suture line apparent.
At all?
At all.
None of them.
Well,
Do we get to see a skull like that?
no.
I want to.
Maybe. I don't know if we still have real skulls here.
Might be.
Yeah, so I don't know. Maybe my skull. Yeah, Josh.
Did you say immovable joint?
Immovable. IMM.
I know, weird.
Okay, so here is an example of some real fetal skulls. Again, you can see the cartilage present there. So you don't have to know any of the details of this. Now, vertebrae, let's get into more axial stuff. Just like in lab, I would never have you memorize any numbers. So don't waste even a second saying, oh, there's 7, 12, 5. You know, I don't care about that. Don't tell me that. But I do want you to be able to tell me some characteristics of each vertebrae. Remember how we're playing the game for lab on Tuesday, is that you have to be able to recognize one vertebrae by itself, whether it's cervical, thoracic, or lumbar. And when we do that, we have to start with the top, the cervical vertebrae, towards your neck. And when we look at the top 2 vertebrae in lab, we remember that they are unusual in shape in that the top one has these big pads that articulate with the skull. In some cases, you can even think of them holding up the skull. So we call this top vertebrae, or cervical number 1, C1, we call it the atlas. So in lab on Tuesday, you were supposed to determine which one was the atlas. It has the pads. C2 has this big pointy thing, and everybody write this down. This is a lecture test question. This is like number 5 that I've given you today. This big pointy thing is called the dens, D-E-N-S. D-E-N-S. It's this big pointy thing. No other vertebrae has a dens, and it allows your head to pivot. And so sometimes you may have heard of people in maybe like a car accident where they say, oh, I broke my neck. Well, how are you alive, right? Well, maybe they cracked the dens, and they need to be in traction so they can heal properly. Okay, so C1 and C2 have special names. Atlas and axis, don't confuse those. Atlas is like the person holding up the world. Atlas is the one with the pads. Axis is the point, the dens. Now you can also see that when we look at a cervical vertebrae, they have these little pinchers. And hard to see here from this view, but they have holes behind the transverse process. Something that I told the Tuesday group to really look for. And I'll tell them the Thursday group tonight, so don't worry.
They all have holes and they all have points.
All cervical vertebrae have holes and pinchers. And I will.
And you said that was transverse process?
Holes behind the transverse process.
Thank you.
In fact, they're called transverse foramina. Plural for foramina. When we get into the, let's see if I show, I don't talk about the thoracic vertebrae, that's kind of silly. But the thoracic vertebrae are the ones that are in the middle of the spine, and they look like a giraffe's head. And the only thing that you probably need to know for the lecture test is that they are the only vertebrae that articulate with ribs. So the ribs kind of meet and join with the thoracic vertebrae.
Why does it look like a giraffe?
I'll show you that. I'll show you mine. All right, so let's take a look at the lumbar vertebrae. These are down by your butt, and these are the ones that typically have the biggest problems in life. I would say that most people, it would be rare to make it to 70 and say, I don't have a sore back or something, I'm stiff, or I have a herniated disc or something like that. So people in occupations like UPS drivers and people who do a lot of lifting, firefighters, that's a good one. They probably are wearing and tearing, listen, this little pad right here called the intervertebral disc. And so right now in you guys, it's pleasant, it's present, it's plump, and it does a good job of providing a shock absorber, allows for mobility. But as you get older, this compresses, and this is one of the reasons why people get smaller in height. So you have compression, and you even may start causing parts of this lumbar padding to project outward. So when you have a herniated disc, it means that parts of this pad are kind of pushing outward, maybe even on certain nerves, which can cause it to be really painful. So take a look at an aerial view of the padding, and notice that we have an outer ring, and anytime you see the word annulus, that means that you have an outer ring. And whenever you see the word nucleus, think of your cheek cell. You have like something in the middle, like a nucleus. And this shows that the nucleus propulsus, this middle part of the pad, had some type of pressure on it. Maybe somebody like was lifting something incorrectly or torqued their back in some way. And it caused this to, look, bulge outward and put pressure on these yellow things. These are nerves. Yeah, Josh?
Can that cause
Sciatica.
like numbness or something?
Yes.
Yeah.
So one of the typical symptoms when you have pressure on a nerve that goes down into your leg is tinglingness or numbness. That's usually called sciatica. My experience with this was when I was about 36. And when I was 36, I think I was the youngest person in the biology department at Xavier. And this guy was moving from this really small apartment in Clifton to his first house. And this apartment in Clifton was like on the 3rd floor, and I had nothing but wood steps. It was an older building. So I went and helped him lift all this stuff. You know, his dresser, his bed, his couch. And we were lifting and like tilting and leaning over like stairs and trying to get it through. And yeah, at the end of the day, I said, man, that was a workout. And then the next morning, I couldn't get out of bed. My wife literally had to take my legs and like set them on the, I mean, it was the most painful thing I ever had in my life. So I had a herniated disc, and the way they treated me was that they injected me with a needle full of anti-inflammatory steroids, and that caused this thing to retract back, and it really worked for me. And I ended up having to get 2 injections, you know, in my lifetime, because once you have a herniated disc, you're always kind of at the risk of having something like that again. And the 3rd time that I did it, I went back and said, I think I need another injection. And they wouldn't do it. They said, listen, even though we have sterile equipment and we don't think that there's going to be any problems, you know, there's risks every time we put a needle in your back. And so, guess what they told me to do? They told me to take 6 Aleve. You know, I'm thinking, oh my gosh, my liver's gonna explode. But they said taking 6 Aleve is equivalent to like 1 steroid injection. So I did it based on the doctor's recommendation, and it worked. So I'm not encouraging you to take 6 Aleve if you have a messed up back, but yeah.
So the only thing that's actually shifting in a herniated disc is this nucleus pulposus?
Yes, yes, yes.
I guess I have this image of like.
The whole thing slided, yeah. Take a look at this. This is something that I think that you guys will hear about clinically, and that is some abnormalities with the vertebrae. Over on the left, you can see what you probably were screened for in kindergarten and gym class. When you're going to the gym or the cafeteria and bending over, and the nurse looked at your back. And if you had some curvature, maybe they flagged it and they tried to put you in some type of brace as you were developing. So this is something that could be kind of treated and fixed. These other ones are interesting. Look at this. This one says kyphosis, and kyphosis is a hunching, generally due to osteoporosis, something we talked about in last class, where the bones become weaker and no longer able to stabilize the torso. So you see people who are bent over like this, holy cow, it's so sad. Lordosis is something that is somewhat temporary in some people. It means that you have more abdominal mass, let's say it that way. So whether you're obese, which you're going to deal with a lot of obese people clinically, or whether or not you're pregnant, that can cause a temporary shift in your vertebrae. So if you lose a lot of weight, or if you deliver the baby, the spinal column can go back to a normal way. So lordosis is something that can be seen in both males and females. Males who are obese can also have that extra pressure. So a lot of times, if you have lower back strain, you're going to hear the dreaded phrase, hey, you need to go get some physical therapy. And then you know what they're going to tell you, physical therapy? Oh, we're going to strengthen your core. Which means your abdominal muscles are really weak, and that's leading to the back pain. So that's basically saying you have some form of lordosis. Okay, in lab, we didn't really hit this very hard, but I do want to talk about this in lecture, so put a star by this. You should be able to explain a couple different characteristics that are associated with male and female pelvises. I didn't emphasize this a lot in lab because I don't think that that's a big emphasis on the lab test. But when you look at a male and female pelvis, one of the things that you can see that it's obvious to me is that female pelvises are wider. So females have bigger hips. That is a biological thing. So don't say I have a bigger butt than my husband because I'm, fat. It's because that's the way you were made. Now some women are born with smaller hips. Like for example, my sister-in-law, she's from Honduras, and she's this tiny thing. She's like as tall as Tosh. She's tiny. And her doctor said, listen, your hips are not, desirable for childbearing, but she had 3 children, they were all C-section. My wife, on the other hand, they said, oh man, you have great hips. You should have lots of kids, So 3's enough for us, but wideness, that's something to think about. The other thing is I want you to look at this angle. It's called the pubic angle. And on Tuesday next week, when this group comes back in, maybe just for fun, see if you can go up to a skeleton and say, hey, this is a male or this is a female. Tonight in lab, go up to a pelvis and say, I think this is a male and female. And all you have to do is go like this with your fingers. You go like this and you say, is it wider than 90 degrees? If it is, look, yes, then a baby's head can get through that.
Hmm.
If it's tighter than 90 degrees, that's a guy. There's no baby's head coming through that. Yes, here.
So, you said, a cubic angle, so
Yes,
is
so
that what
that's
it's called, or?
that's what this, so pubic arch and pubic angle are the same thing.
Okay.
Yeah. Okay, so that brings us to the end of bones for lecture, which I think we talked about some interesting things, but I think you only have to know 3 or 4 bones, right? So that's not bad. Now, what gets a little crazy is our next topic in lab. So on Tuesday and Thursday of next week, we're going to review the skeleton and talk about joints. So there will be joint stuff on Tuesday's lecture test. So notice the name that's associated with joint science. It's called arthrology. Now stay with me. Write down this suffix, I-T-I-S. I-T-I-S. You've had bronchitis, you've heard of pancreatitis, and now, of course, you've heard of arthritis. Anytime you see the suffix I-T-I-S, don't forget this, it means inflammation of. Inflammation of. So our last 4 slides of today's lecture is going to be dealing with the issues of inflammation of joints, arthritis. We're going to be talking about the different types and their characteristics. But for now, we're going to talk about, look, the 3 major classifications. So underline this in your outline. You need to know an example, here we go, of a slightly movable amphiarthrotic joint, a freely movable joint, diarthrotic joint, and one that there isn't any movement, like a suture in your skull. When you're an adult, that is. There's no movement. In lab, you will even go into a little more detail and say, okay, in addition to these 3 major categories, movable, slightly movable, and non-movable, you can tell what type of material the joint is made of. Not so much in lecture. So here's what I want you to know for the exam. Let's focus on examples of these 3. Know that these exist, but we'll say that the examples of this bottom bullet point is more for lab. More for lab. So the best way to study this information is to look at the lab chapter for next week. So that's the best way to attack. When we look at any joint in general, you can see that joints have a typical anatomy, whether they're movable or slightly movable. And you might remember, look at this, the epiphyses of the bone, and look, there's the epiphyseal line, so this is an adult bone. But remember what we called the outer surface? We said there's articular cartilage. And we said that that was designed to be a slippery surface, so there's gliding. Like, I'm doing this with my fingers, I don't hear any cracking, thank God. It's not painful for me, right? So everything in this figure still exists in me. But sometimes, whether it's an immune system or whether it's just wear and tear, this white shiny material starts to wear away and it becomes really painful to move joints. So let's talk about some general characteristics. I would write a few of these down. One is that we have articular cartilage. We have something called a joint capsule, which means there's kind of a protective outer covering. And with diarthrotic joints, ones that are freely movable, we even have another lubricant called fluid, sometimes called synovial fluid. Sometimes we even have a third lubricant called a meniscus, which is another way of saying I'm ensuring gliding and not grinding. And if the joint does a lot of moving, sometimes we have stabilizers, like ligaments, that protect us from hyperextending or doing something really serious. Okay, so that is a typical joint. Now, for the next two slides, we're gonna talk about something not very fun. This is the physics of moving a joint. And we're not gonna go crazy here. But it says that when a joint moves, it's based on a couple different things. It's based on the length and the maximum kind of pressure of the joint bones that are involved. The length of the bones and the pressure that's put on the bones. One of the things that I think about when I see these next couple slides is I think back to like the Discovery Channel or the Learning Channel, whatever channel that was, about 6 or 7 years ago. They would have these hypothetical like battles. I don't know if you were into that. It would be like saber-toothed tiger versus a lion. You know, who would have won? You know, an alligator versus T-Rex, you know, something like that. And so what they were looking at was the jaw joint in most cases, because that's the joint that goes in for the kill, you know? My German Shepherd is the sweetest German Shepherd. I mean, she is a gentle giant. She has bad hips. She can barely get up and barely do anything. But if there's like a possum in our yard, that possum is history, you know? She will get up and run, like I didn't even know you could still do that, and then she'll grab that possum and just go like this, and not do anything, but just kind of just lock in. Yeah, and then the possum's dead. And no, not faking, but literally really dead, you know? So animals have that power. So one of the ways we can measure power is by measuring something called mechanical advantage. And just write that word down. Some joints or some levers, if you want to get into physics talk, are designed for power, and some are designed for speed. The joint that moves your mandible, your jaw, is designed for power. And that's how you really dictate whether or not an animal would win in a battle, is how fast and how powerful are their jaws. So I want you to write this equation down. It says mechanical advantage, ready, equals the length of the effort arm, whoa, what is that? Over the length of the resistance arm. Don't panic yet. Don't panic. So just remember, effort over resistance. Effort over resistance. I'm going to have one lousy question on the test, it's a promise, where you're going to have to do old school long division. Now listen, you might say, Mike, that's one question out of 70, I'll just chop that one up. Okay? I'm not going to do that one. But if you are the type of person who wants to get like 106, you know, and you say, oh, I got to do so much better than the last test, then you might practice doing some long division without your calculator. Like, just practice, okay? So I will give you the length of the resistance, the length of the effort, ready? And all you will have to do is do that simple math. And remember this, that if your answer, your mechanical advantage, is greater than 1, here's the money answer on the test, then the joint is designed for power. If the mechanical advantage is less than 1, then it's designed for speed. So that's kind of interesting. And for people who are into biomechanics, maybe that's something that you might really be into. You're into like engineering kind of a mind. You like to build things. You love anatomy. You might be into biomechanics, building new like prosthetics or something like that. How sweet, that'd be a cool job. You're going to have to know a little bit about physics, and I want to just give you an exposure to it. So on the exam, I will give you the numbers. You just have to remember what to do with them. It's the length of the effort over the length of resistance, and remember what the answer means. Okay, that's it. Okay, now the next couple slides are ones that talk about when we look at a joint, how do we describe the movement of the joint? And I think some of you have talked about maybe these terms before. I'm sure you know some of them. Some of you will say, I am not flexible. you know, I can remember in high school back in the day, this is way back in the day, this was before you were even conceived, I was the captain of the soccer team. And I can remember getting all the guys saying, all right, toe touches. And I'd spread my legs, it'd be just like this. And, I'm not gonna do it because I'll probably mess up my back. But I can't even barely touch my knees, let alone like my ankles. And there were people that were like picking grass, scraping the floor. Man, I can't bend over. I'm not flexible. I'm not flexible. And then there's some people who say, listen, my ligaments are so loose, I can hyperextend. Hey, Mike, look at this, you know, and do all this crazy stuff. Don't show me, I'll start gagging, you know. I can whip my arm out of socket. I can do all this crazy stuff. So when we think of like America's Got Talent and you see all those psycho people doing those things, how do you explain it? It's because of the tautness, ready, of their ligaments. I want you to write this down. A ligament is connective tissue that attaches bone to bone. A ligament is connective tissue that attaches bone to bone. A tendon is connective tissue that attaches muscle to bone. All right. So from the big green book, you have a table that looks something like this. Notice these crazy names. And these are all types of synovial joints, which means they are probably diarthrotic joints. They have fluid as that extra cushion. So in lab, ready, you will need to know an example of each one of these. And I'll talk about that next week when we do joints in lab. For lecture, we're going to focus on synarthrotic joints, amphiarthrotic joints, and diarthrotic joints. So the only thing that stinks when it comes to joint or arthrology, the study of joints, is the use of these terms. So I will probably have 4 questions on Tuesday's test to deal with these terms. And if, let's see, David, you have the big green book, right? Can you turn to this chapter and tell me, is this still legit? Megan, maybe you can tell me too. Is it 8.4 to 8.5, or is that the blue book? I can't tell.
Blue book as a woman.
Oh, I don't care about the sex. I'm talking, starting on 8.4, is it all those terms?
Adduction and lateral flexion.
Yeah.
Extension.
So you have the old book.
Okay.
You have the green book? Megan, talk to me, girlfriend.
I was looking for it.
Let's go a little faster. Is it 8.4?
Yeah.
Yeah, no, that's not it. Is that legit?
We looked at it, I think it was.
Yeah.
Okay.
Yes.
So it's yes, this is legit?
Oh, yes.
Oh,
Oh, no.
man, legit. I thought this was the blue book. So this must be the green book. Okay. So remember, when you're studying these terms, just know the ones that are in your green book, or blue book, whatever we call it. So if I say, hey, what is an example of giving, this is what I asked on my Xavier test on Tuesday, giving the peace sign. Look, I'm spreading my fingers apart. That would be, look, abduction. I'm spreading them. What about this one? Here's a good one. Nodding yes. So when you see that question, you think of maybe flexion and extension. You guys getting it? That's the kind of question I'm asking. You guys don't seem very close. Okay, the only joint, and there's lots of joints that I could have you guess.
I'm
Joelle.
sorry, you said synarthritic joints and then 2 other,
Amphiarthrotic and diarthrotic. Those are the three major classifications. Syn, amphi, and di.
thank you.
The only joint that I'm going to ask you to know something about is not the hip joint, not the shoulder joint, even though I think that's interesting, especially if you're into baseball and you're into like things like the rotator cuff. It's the one that has the most problems, and that's the knee joint. So here we go. figure 810. Now, I'm gonna tell you this, you're gonna have a panic attack for about 10 seconds, and then everything's gonna be okay. Ready? This is the last page of the exam. Take a picture of it if you don't have it, if you don't have your book. This is the last page of the exam. So as I'm looking around and seeing like 20 people not here today, where's my brother Vince? So someone tell him I called him out. Vince is gonna leave that page blank. He's gonna say, what? So do you have to know all of those? Yes. But so many of them are repeated. Listen, so many of them are the same thing, but just different view. So I'm going to, listen, put this exact figure, 100%, minus the labels, the same lines. So you can go on Google Images, just like I'm doing. You can find knee joint unlabeled on Google Images. And you could probably find this exact same one. Make about 10 copies of it. Practice labeling it, and this is the last page.
So will it be like how the lab experience, like the lab thing was like certain, you gonna ask for certain things, or we like you mean literally like everything is gonna be named?
I'm not gonna ask you to label everything, it'll probably be just 10, I'll choose 10 blanks. So you'd have to know them all, but I'll just pick 10 blanks. But a lot of them are repetitive, just from different angles. Yeah, maybe.
Are we gonna have to like know like the exact spelling or close enough to the exact?
Close enough, close enough. And if it's lateral, if it's LCL, you can just say LCL. You can say
Oh.
ACL,
So we can just.
yeah,
say
MCL, LCL, you can just use the abbreviation. Okay, so when you turn in the test on Tuesday next week, the first thing I'm gonna do is give you a look, and Omkar's gonna say, I did better. And then I'm gonna immediately turn to his last page to see if he did this. Yeah, that's what I'm gonna do, because I bet you, even some of you are gonna blow this off, but you can't afford to, right? All right, some of us have seen some very disgusting injuries, especially if you like watching sports. But one of the most interesting things about knee injuries is that a lot of people believe now that there's more injuries that are prone for females because of the way they are made. Which means that the supportive tissue, listen, your quads, not your hamstrings, but your quads, may need more work, may need some more development. So nowadays, like if you play club soccer, you know, a lot of clubs are having trainers, instead of spending 30 minutes with ball drills or whatever, they're spending 30 minutes working on muscular strengthening. Because, you know, I have a daughter, she was really active in sports. I saw so many of her friends having knee problems, you know? And maybe it's not just a fluke thing, maybe it's because we're not training them right. Something to think about, Amanda.
I think that's a huge thing though, because these, like, think, how do you train these tiny little like micro muscles and like labels
Yeah.
and stuff? When I did a Spartan run, and when I was done with it, that's what hurt. That's what I couldn't. Everything where everything attached, you know,
Yeah,
the
yeah.
tiny stuff is really hard
Yes, you have to
to
strengthen
protect.
Here you can kind of see a close-up version of how we have ligaments that prevent certain movements, anterior and posterior. We have lateral and medial. These are all designed to be like power cords that say you can't move in a direction like this. But if you're forced to do that, it's obviously going to put stress on those legs. All right. Last 4 slides of the day. We're doing great. We're going to be out of here in 10 minutes. So usually I say we'll leave early, and we never do. I think well, I'm not going to jinx it. I might get on a roll and talk for 25 minutes. No, I won't. So remember, arthrology is the study of joints. Inflammation is arthritis. And when we think of arthritis, you might have a grandparent in mind. For me, when I think of arthritis, I have 2 people that I think of. I think of this former student of mine who was a college basketball player at Xavier, and then I think of my grandfather's friend who had rheumatoid arthritis, His fingers were like this figure, they were claws. And as like an 8-year-old kid, seeing that man's hands, it's something I never forgot. I remember going to my mom saying, "What's up with his hands?" You know? They were so disjointed. So what I want to do is talk about the different types, and there's 3 types. So the first one that's up there, and be able to explain these, your last gift for the exam, there will be a written question for these 3, is osteoarthritis. And one of the things about osteoarthritis is that it's known as the wear and tear form of arthritis, usually associated with just years of use or intense use. Every year I go to Lakota East High School. I don't know if anybody knows where that is or went there, but Lakota East, I go there and I give a talk, an anatomy talk. Usually it's hearts or something I talk about. And the reason why I go there is because the teacher I had in class about 15 years ago, and she was like the star point guard for the Xavier basketball team. She got inducted to the Hall of Fame a couple years ago. Really neat lady. And when I came in 2 years ago, she was on crutches, and she's like 34, so she's not that old. She had double knee replacement at age 34. And she said, "Yeah, the doctor said all those years of basketball." And then you think, well, wait a minute. You want to be active, you want to be physical, but then this happens, you know? So that was, you know, intense, right? And so her knees just said, you know, I don't have enough lubrication and padding. It was painful. Let's put in some new knees.
Could that just be genetics, though?
It
Man,
could
that's
be.
what I was gonna say.
It could be. The doctors seem to think it was more wear and tear. You know. The problem with wear and tear arthritis is that when you are diagnosed with it, there's no cure. So you have it and you will have it for the rest of your life. And generally the only thing that you can do when you're diagnosed with osteoarthritis is just kind of manage the pain. So you could take Tylenol, arthritis, you know, version or something. David?
So yeah, I think genetics does play a big part of it. There was a girl in my high school who had those knees replaced before she was in 10th grade.
Oh my gosh.
And she played basketball, and she would cry during her games, but she'd still play. She loved it so much that
Yeah, there might be.
yeah, she was great.
Yeah, Megan.
Actually, syndrome called EDS actually can cause arthritis.
What does
as young-
EDS stand for?
Ehlers-Danlos syndrome.
Oh,
It's like
yeah,
I
yeah,
suffer
yeah.
with.
Yeah.
But it causes arthritis at a very young age. Like my brother already has arthritis at 23. My dad had it at 19, and it's genetics.
Yeah, and that's also
50-50
probably, so gosh. So when we talk about osteoarthritis, we can see that it's the most common form. I call it the wear and tear. Sometimes it's called the degenerative joint disease, but it's usually large joints that are affected, like knees and hips, shoulders, lower back, upper back, usually. And you can see that the cause is that things become stiffer, the cushions become depleted, and it's just flat out painful. So osteoarthritis, our first type of arthritis, know how to explain it in a couple sentences or 2. Let me show you a diagram of where you can find osteoarthritis. You can see that these are the hot spots. Again, major joints, knees, hips, shoulders, vertebrae, lower and upper. And then when you look at it, take a look at this. Here is a healthy joint. Everything that we've talked about, there's the articular cartilage. Here's the capsule, here's the fluid. There's a lot of gliding here. But down here with osteoarthritis, you have no articular cartilage, and you have these chunks of bone floating around. So some of you have heard of bone spurs. You know, you've heard that with athletes. That's gotta be painful. So that's something that can lead to wanting to have your joint replaced.
When you can feel like the weather change, like in your joints,
Yeah.
is that like the early sign of arthritis?
I don't know about that, you know, that's a great question, Tom. Dominic, I don't know. I've heard people saying that they can tell when rain's coming when they're, you know.
Yeah.
I don't know, I just think that might be for
Mary,
When you crack a bone, like, is that synovial fluid breaking out?
100%. So that's not gonna lead to arthritis, that's just like displacing the fluid from one side to another. Yeah, so it's disgusting, it's not gonna cause a problem. Let's talk about rheumatoid arthritis, and when I say rheumatoid arthritis on the exam, the first thing that I want you to write down is the word autoimmune. So this type of arthritis is seen in little kids at Children's Hospital right now. It's caused by your immune system attacking the joints. And it usually attacks only small joints, like fingers. That's the hot spot. So as I said, it can begin at any age. It affects the small joints. Some people think that your immune system kind of gets tricked into attacking joints by being exposed to some type of viral or bacterial infection. So rheumatoid arthritis is a tough one. Also, I want you to circle this term, pannus. This is a description of the outer kind of synovial membrane or capsule that becomes so enlarged that it disfigures the joint. So it doesn't just cause pain, it can cause the joint or the bones to shift and no longer even being functional. So that's the memory that I have in my head of that friend of my grandfather with fingers that were all like distorted. His joints were just like moved because of the pannus. And so when we think of the pannus, you can see that it's just an enlarged or inflamed joint capsule. Again, fingers primarily go on the spot. Now, when we think of rheumatoid arthritis, you can see that you can get into much more detailed explanations on how antibodies, which is a part of the immune system, can affect. But you can see that arthroplasty, that's an interesting term. Arthro for joint, plasty means change. So changing a joint or replacing a joint sometimes is with some type of prosthetic, right? Which could be a metal device, or it could be a cadaver piece of tissue. So there's a lot of different kind of options to help with joint replacement. But a lot of them are synthetic. And when we talk like, for example, knees and hips, the cadaver that we had at Xavier this year had both. The same person had a knee and a hip done, and when we got into the knee, it was just like this bright silver metal. You know, it was just something that would not degrade over time. Here's a picture of someone's fingers who has rheumatoid arthritis. Take a look at that. You can see that the joints, the bones are being pushed out of their normal orientation because of the pannus. So I'm sure that you've seen that before. Here are some prosthetics. This is the fake hip bone or the head of the femur. And one of my best friends is a orthopedic surgeon at Christ Hospital right now. He does hips all the time, and he says that his surgery is just like going to Lowe's, you know, or Home Depot. There's a lot of sawing, there's a lot of pounding, there's a lot of measuring, you know. So, yeah.
So that's actual bone that they put it into though?
So this is metal. and
No, so the one on the left.
So
prosthesis.
yeah, so this is what it would look like from a cadaver. So this is, they wouldn't put this into another person. This is what it would look like.
No, like, do they take it out and they?
No, they just hammer this baby right down through the middle
Right down
of the
the middle.
medullary cavity.
Oh, wow.
Yeah.
Does the medullary cavity make up for the
Yeah.
artificial thing being in there and still create the blood and
Yeah,
And
now,
the
in an older
osteo-
person, there's not much going on in the medullary cavity. Remember, it's just mostly fat or reddish
Oh.
jelly. So there's not too much concern, but, you know, they wouldn't probably hammer something like this into like a 20-year-old. They'd probably look for other options.
Is that why they wait until you're older to do
Yeah.
hip replacements?
Yes,
Okay.
100%. The last type of arthritis we're gonna talk about today in our last slides of the day deal with something called gout. And this may be a joke with somebody, you know, like, oh, I've got the gout, you know, and I can't go to work. But gout is legit. Gout is the buildup of something called uric acid. When you look at that word uric acid, I hope that you kind of see the word urine in there somewhere. So in most cases, we pee out stuff that makes up uric acid. But for those people, this is a genetic link, so you're not going to develop gout all of a sudden. But those people who have the genetic link don't pee out the ingredients that make uric acid, and it crystallizes in weird places. And one of the most common places for gout is your big toe. And you can be the manliest of men or the most womanliest woman, and you're gonna call into work saying, I can't come to work because my toe hurts. And if I didn't know this, I would say, man up, woman up, get in here. Like, what are you talking, your toe hurts? No, they say it's like unbelievable pain.
And it's pee in your toe. Look,
It's
basically,
uric acid,
uric acid.
which usually comes out in your pee, but it's not urine.
But would that be like something like because of kidney function? Like,
Yeah, that's very good. Good job, Dominic. Yeah, so that means that uric acid or the ingredients are usually kicked out by the kidneys. Yeah, so it could be ultimately gout is related to kidneys. That's 100% true.
So could an Aleve, using a lot of Aleve and stuff like that? raise
No,
your
Aleve
chances?
doesn't affect kidney kind of.
Which one
filtration.
affects your kidneys?
Liver.
Oh, that
Like
affects your
there's-
liver.
Alleviates
Which
liver.
one? Yeah.
Alleviates
Okay.
liver.
There's
So
one that affects your kidneys,
omeprazole,
though.
omeprazole is, and things that are designed for like, acid reducers affect your kidneys.
Okay, but like could
I don't know.
basically being stuck on one probably raise your chances?
I don't know. You may have seen a commercial of a dude holding a flask, and that flask was to represent this poor guy who has just too much uric acid, you know, and trying to eliminate uric acid. So there's medications that help, but the other thing that I want you to write down with gout, and this is the first time that I've ever used this term, but this is very common in the world of anatomy, is that this is the only type, and put a star by that, the only type of arthritis that experiences flare-ups, which means it comes and goes. If you were diagnosed with osteoarthritis, it's something you're gonna be dealing with for the rest of your life. If you have rheumatoid arthritis, RA, you may have heard of that, you're gonna be dealing with that. Maybe controlling it with some medications that are out, but dealing with it for the rest of your life. Gout, you may have something this weekend and it may not come back until the summer or the winter or next year or next week. You just never know. Some people think that it's linked to certain medications or foods, like they'll say, man, if I really go out and drink a lot, I've got the gout. Or if I eat a lot of like greasy food or meat or amino acids, I get the gout. But there's no clinical proof that food and diet cause. Some people will say, well, that's not true. But clinically, it's not there yet. Joel.
So my husband has gout.
Oh,
and
yeah?
we
Where does
did
he
it,
experience it?
we did it's awful.
Where?
His toe.
His toe?
But we did an elimination diet and it turned out pears was what was causing him to flare up, because I would make these little salads with pears in them a lot and whatever, and we never made the connection, but we finally figured it out. And since he stopped eating pears,
He
he
has not had a flare-up.
hasn't, so he has to be careful with juices, because sometimes, you know,
Like citric
juices can
acid.
have additives like apple juice and pear juice in them, so he just has to be careful about that, and he hasn't had one since, so.
Wow.
Yeah, it's weird. Something about the sugar, the way the sugar is in that particular,
Okay.
the sugar in that particular fruit causes it, so,
My
yeah.
dad gets it with steak.
Good.
Steak,
yeah.
God.
Usually
poor
I've
guy.
heard,
He doesn't do it very
I've
often.
heard meat and alcohol are big triggers.
I know, it's
Like, he'll,
weird.
like,
Pears.
he won't get it, and then be like, I'm gonna have a steak, but go out, like, with work, next weekend,
Oh.
done.
I've got to go.
So it's like
So
last
Joel,
week
when
I
he has
had
toe
that.
pain, is he like a baby? He can't like get out of bed?
Oh, he can't, nothing can touch it. I mean, the sheet can't touch it, he can't put a shoe on. It's horrible, it really is horrible.
But does
So,
it look, does his toe look any different?
no, it's not typically swollen, it's just really, really super
What is it
painful.
about
Does it
the
get red,
intravascular
hot?
that makes it so nerve
I don't know about the
sensitive
hot.
or receptive?
It's not hot to the touch.
Yeah, it becomes crystals.
What, the actual toe or inside?
The air gas.
So if your husband has toe pain, how long does it take for it to go away?
Well, he drinks tons of water and he takes anti-inflammatories and it takes about 3 days. Once it flares up, it takes about 3 days to calm down. So.
All right, so there you go. Get out 5 minutes early.
If it happens again.